So the topic that Dr. Pradeep had assigned to me is about the disease modifying therapies or the newer medicines. So the newer medicines are the ones that have created all this interest. So when they came, they sounded like a miracle. They sounded like something incredible, and it is incredible. It is as incredible as penicillin was. So many thousands and lakhs and lakhs of people died during wars in the past, World War One, for lack of antibiotics. It is as simple as that. Let's forget the crores and the lakhs. We are healers, we are physicians. We're not here to think about how much it costs. These are simple molecules. They will become accessible. Considering the fact that this is the commonest cause of infant death in the world, it will one day become. So I'm older than many of the doctors here, except Sir, maybe. But the rest of you, you are going to face a world where we are going to have to give the DMTs. But why we call them DMTs and not newer therapies? Because it is changing history. So you're getting more problems. You're juggling two balls. You've got a third ball, a fourth ball, or a 10th ball. So that is what is happening. So wanted to give an overview of various DMTs that are currently available. And what is most important is the right time to start the DMTs, and underpinning it all is the standard of care. We won't touch upon it this time in this talk much, but mention it: single versus combinatory therapies and the challenges ahead. Even when we had no treatment, there was challenges. One would think that we have less challenges. No, we don't. We have more. So we, the medical fraternity, have to be more geared to handle these challenges. So I'm not touching on this. Dr. Pradeep has already mentioned that this disease causes progressive weakness, and this is what SMN1 and SMN2 do, and that it causes weakness, muscle weakness, and atrophy. So simplistically put, you have type 1, 2, and 3. So, but now we are changing this. We are no longer, so we are changing type 1s, 2, and 3 by giving them disease modifying therapies. So in your head, let's erase type 1, type 2, type 3 and keep it as non-sitters, sitters, and walkers. This is important. So as a geneticist, when Dr. Pradeep said 1, 2, 3, the 1, 2, 3 is important, and there are more nuanced classification. There is a 1A, B, C, there's a 2 is 2, nothing else. 3A and 3B, all of those things, and a 4 separate. And remember, medicine is all about classifying because we're a very practical field. We are trying to deal with the problem that is in front of us. The patient who has a cough or a cold or a fracture, we need to understand that we have to deal with it differently. So it is giving us a landmark, a compass, so to speak. So this is a useful classification because a type 2 child who is a sitter could have lost head control and become a non-sitter. They have to be treated like a 1 with regards to the risk of swallowing difficulties, GERD, and sleep hyperventilation. So non-sitter, sitter, walker. And SMN2 copy number, the number of copy numbers ameliorates, reduces the severity of the phenotype, usually, by and large. There are exceptions to it. So I'm talking about one first child, whom I saw about 8 years ago. He was 2.5. He was admitted to our PICU, a very smart, astute pediatrician. So I was a pediatric neurologist in this hospital. This was when I was working in Rainbow. Noticed a bell-shaped chest when they looked for X-ray for pneumonia. At the same time, managed to capture parental consanguinity, firstborn child. Parents were not able to give the history of developmental delay, no head control, because nobody's expecting a 2.5-month-old to have head control. But we immediately sent off genetics, and the genetics came back as SMA. So child had already had contractures. This was the reason I put the year is because we did not have disease modifying therapies in that year. So we palliated the family. What we were able to achieve was we sent an expensive test. We had to pay double the amount of money that was SM and MLPA, because ventilated child, just paying 10,000 instead of 4,000 or whatever was there at that time was useful, because every day in the ICU is more. So we were able to get in 5 days, we got a report, we were able to counsel them proactively and say, look, not going to happen. We're not going to be able to extubate. So it guided our therapy. It was sad and tragic, but it wasn't dragged out and prolonged where everybody is helpless. Doctors are helpless, families are helpless. And we were able to give them a diagnosis. So I'm going to glance through this. He said, so the concept is SMN1 is the key. It produces 100% functional protein. SMN2, and it accounts for 90%. SMN2, unstable protein, truncated protein. So your strategies, understanding that is key to understanding the disease modifying therapy. Your strategies are all, remember, all that we have currently for DMT is all dependent on making SMN protein available through product expression or production. So there's one way, one strategy is increasing the efficiency of the SMN2 protein. We can do that by Spinraza or nusinersen, where you get stable, there is an antisense oligonucleotide that attaches itself to the existing faulty SMN2 or the unstable one, and at the mRNA level creates a more stable transcript. So that is nusinersen. This was first in 2016. Then you have the small molecule called as risdiplam, which is a splice site modifier. Again, end result is the same, more stable transcript. So then there is another strategy where you're saying, okay, SMN1 is absent. Get SMN1 packaged and delivered like a post and restore the SMN1 gene. This is using the envelope, that is the AAV9 virus called as Zolgensma. So that's what nusinersen does, and that's what AAV9 virus Zolgensma does. So you have two strategies right now. You have onasemnogene abeparvovec Zolgensma, which on very cheap, only 16 crores. So far we have about 34 children that we have given this to, and SMN2 splice modifier, nusinersen. So that was our 2019 first patient. As you can see, I'm looking much younger there. That's about 2.5-5 crores a year annually, and we have around 26. And then we have the risdiplam, which costs around 73 lakhs annually. So now I'm going to pose a question. As physicians, we all learned what we had to do. Depending on the year you passed out, you were told, okay, this is the disease, this is how to treat it, this is the outcome. So this is the picture that was sent out in the US when they started advocating for newborn screening. They picked up this little girl, Lucy, and treated her pre-symptomatically, and she was walking, and she was absolutely fine. So this is bringing into point questions like newborn screening, early diagnosis and intervention. And I mention these points because whenever I go for international conferences, we meet countries from all over the world. So UK has got different resources to Israel, has got different resources to Belgium, to US, to Canada, to and Africa or India. All of us have different ones. But this is assuming early diagnosis and intervention. So what happens is, so that's one side. Many of you would have seen this on news a few months back. I don't know how many of you have seen this, that there was SMA treated in the womb. Has anybody seen it? No one's seen it. Anyone? Yeah, you've seen. Yeah, you've seen. So this came on Twitter. So this came on social media, and it was doing the round in the IAP chat boxes. So this is true, antenatally, and this was published by Professor Finkel, Richard Finkel, so who's a pioneer in SMA. So they identified a child who parent had one child who had SMA. This was antenatally diagnosed. So you may question very well, okay, why was it allowed to go to term? Why was it not prevented? Now there comes ethics, what the family wants and doesn't want. And then if they don't want, then who provides for the resources? All of those are different questions. As doctors, not here to judge all those things. As a society, together we have to decide what is just and what is not just. So anyway, this family at 32 weeks, 32 plus 6 weeks, this child, they decided to start the mother on risdiplam. They gave the mother risdiplam and continued giving her until delivery at 38 plus 6 weeks. And then they delivered the baby. After 8th day, they gave risdiplam. And at 30 weeks, the child is still asymptomatic. But there's a caveat here. He's asymptomatic for SMA, but he has ventricular defects, brainstem abnormalities, and optic nerve hyperplasia. SMA, as we are beginning to understand, is not just anterior horn cell. It is expressed in the gut, it's expressed in the heart. So many of them are getting intraventricular defects and things like that. So many of these children with a severe disease, they never survived to tell the tale. We just saw them and they just died in our nurseries. We are seeing many of our children now that we're disease modifying. Do SMAs traditionally, do we know that they have heart disease? Traditionally, we are not taught they have heart disease. I have seen 2 children with ventricular tachycardia. One who was arrested in front of my eyes after giving Spinraza. So that's how we lost one of our children. So there are so many other things that we don't know. When we disease modify, arrhythmias are becoming a bit more they're being revealed. So congenital anomalies. So for our knowledge, this is what is approved right now. So nusinersen, onasemnogene, and risdiplam. So nusinersen, 2016, 2019, and 2020. So this was intrathecal loadings. The intrathecal injection has got loading phase and maintenance phase. So currently, I can see that some of my young people, okay, not children, but some of our people, children and young people with SMA and getting nusinersen, they are here. They're very brave, but sometimes it's quite difficult giving it intrathecal again and again. But they have not been unsolvable issues. So 4 monthly maintenance. There is a newer medicine that is being developed, which is once a year injection instead of 4 yearly injection. That is a newer medicine that is being developed. So only 78 lakhs, very cheap. So luckily, around 200, fortunately 200 children in India are being given it for life free. But that's it. That company is going under. They're not giving any more new patients because the new company which is making it once a year is beating this company out of finance. So loading dose, maintenance dose. So these are all the celebratory pictures we took with the NGO that gave us, the US based NGO that donated the medication to all of us. So this is a picture of a child who, I put this picture because this is a child who lost weight in 3 months because he was more ambulant. So immediately after giving Spinraza, within 3-4 months, he lost weight. But so while we were all celebrating about it, it's also a slightly sad story. Sad story because the second brother is also affected, was not selected. So he's fallen out of the picture. He's not with the same family. He's with somebody else. So there's so many other things that we as physicians feel helpless dealing with. So risdiplam, pre-mRNA splicing modifier, and these are the various dosages, the appropriate dosages for anybody interested. The timeline of development of the risdiplam and when it was approved. So August 2020 it was approved, US FDA approved, and October promptly approved in India. A conditional approval given by the CDSCO. So this was the first family from Tamil Nadu that came to our center whom we gave risdiplam. We gave it before the approval in India, 25th of August 2020. So there are some side effects, but none of our children have had terrible side effects. Many of them seem to have side effects which seem to be temporarily associated and maybe mostly connected with the disease per se, natural history per se as well. So this is a child, one of our children with SMA type 1 who received risdiplam. So many SMA 1s do not have the ability to articulate, make words. After giving risdiplam, he was able to speak. So gene therapy first, we were fortunate enough to give it on the 20th. We took it as an omen, as a sign. 21st day of the 21st year of the 21st century, 21st of January 2021 was the first time, and then we were able to give it. They gave it to us through the Global Managed Access Program, where it was donated free. So then, on June 2021, there were 3 children who got it in the same day. So this is one of our better patients. He's a type 1, but he improved very well. So the reason I'm showcasing this guy is because he's what is textbook. He had no head control. Within almost 4th week, he had head control. Now then because he was given very young, not very old. So after a certain amount of anterior horn cells are dead, giving it is not very useful. Or it's not that it shouldn't be done. It should be, for 4 months post, he's able to roll over. And 10 months post, he's sitting. Now he stands with support. He doesn't walk, but he stands with support. So that's him. To summarize, gene replacement, Zolgensma, or make SMN2 more efficient, nusinersen and risdiplam, but underpinning it all is SOC. So this is a cautionary tale. So this is one of our patients who received gene therapy. At 2.5 years, she was really, really scrawny at 4.7 kgs. Not much gains were achieved from the Zolgensma. Her gastrostomy and other things. So this is a parental belief that, these things don't matter. Give this 16 crore rupees. That's it. Give us this medicine. Ultimately, we had to redo the gastrostomy because it was done without fundoplication. In neuromuscular diseases, no head control, always gastrostomy with fundoplication. No tests are needed to be done because the tests itself are, including your assessing swallow study, is too risky. You're going to risk a pneumonia, which makes their anterior horn cell disease worse, and they're going to lose it more. So the moment we did that, she had so much chronic malabsorption that she had diarrhea whenever we give, whatever feed we give. So parents will always attribute it as, in the formula seriagala, and the formula seriagala. No, it wasn't. It was just villous hypertrophy. you're in chronic malabsorption. We had to admit her, give her infusion feed pump, slowly, build it up. And then after that, we made the parents put this on their, we said, put it on your mirror. This is your goal. You have to make it like this. She then became nice and chubby. She started gaining milestones. Gene therapy did not give her milestones. We were stealing all the milestones by not giving her nutrition. So gene therapy, rocket science, no use without basics, which is why we are here today on a Sunday. So this is two scenarios. As you can see, okay, I'm going to make it mute for us to remember. But this is, I have to confess, these are two children who continue to haunt me. Both are SMA1. Both were given late. So giving late is a no-brainer, it does not work. We know that. One was given at 22 months, one was given at 26 months. Now this is the previous child from the previous video who got risdiplam. He was bridged at 5 months when he did not lose so many anterior horn cells. She was bridged at 12 months. So by the time she came to us, she was so weak. I remember this family had fundraised. I remember talking to the parents and saying, shall we not do it? It's not right, giving it. And the father was very adamant. They were a very motivated family. They had educated family. Mother had given up her job. They already had another child, but they were right decision that they were very they had a lot of attachment to the child. So we said, shall we not give it? The father said, yeah, go ahead, give it. And I said, no, I will not take your answer, because ultimately care of burden falls on the mother in our society. Usually, we have exceptions. We have fathers who take the burden. But by and large, majority of the care falls on the mother. So I told her, I'm going to have a separate conversation with the mother. Only if she agrees, I will do. So we spoke to the mother and she said, no, doctor, do it. We did it, not much benefit. Little benefit. We had no patient with zero benefit. She was able to hold her hand with a syringe. She was able to terrorize her little brother who was 7 years, older brother. The whole room was controlled by her. But she passed away after some time. She didn't make much. She lived for 2 years after that. But this fellow is standing. He will never walk, but he's fine. Because, so bridging is, the combination therapy is the way forward. But so there has to be, these decisions are very difficult for physicians. These would have to be made with multiple people, specialists, to say when is the right time to intervene. So this is just to put in there. So this is our list of, this is a 2-year-old slide. This is our list of all the children with gastrostomy fundoplication that we've done. And they're the ones who have done reasonably well. And these are some of our children. This is a type 1 SMA. So she got it very early. This is a type 2 child who's walking. This one's from Karnataka and this one's from Tamil Nadu. And so the way forward, yeah, we wish, newborn screening. But I put a question mark because this is the US in 2019, where there were so many states that got it, states that did not have newborn screening. 2021, where there are more states who had it, and this is the same Lucy. But this is India. We are still living here, where we hardly have few newborn screening. And even when we diagnose something as simple as congenital adrenal hyperplasia, by the time you notify, the patient is dead, because our turnaround time is only 1 month. So we have to rethink what does it mean for us and our logistics. So there's new hope for children with SMA. It requires SMA, like more rare diseases, will need specialist centers. Increased awareness among medical fraternity. You have a cold or a cough that is not going away, among parents, so that we can have better informed care decisions. There is not going to be a perfect drug, but we need to look for better solutions. And collaboration is the only way around. All of us, different levels of people working together. So we do think DMTs are a way forward, but it's not the only answer. Thank you.